This is a speed USMLE quick review on chronic bronchitis. And we're going to do it case study style. So we're working at a walk-in clinic, and a patient walks in, and he's a 58-year-old man who is complaining of chest cold with runny nose, cough, and he makes note also of a daily morning productive cough that he's had for the past 2 years. On questioning, he also has a habit of smoking a pack a day since the age of 20. So what is the most likely diagnosis?
You're saying that the patient has been smoking for the past 2 years, every day, a pack a day, which is a lot.
Mm-hmm.
And then also you mentioned that every day for the past 2 years, the patient has been having that morning cough.
Yeah, the morning
that
cough.
is productive.
That's right. So he comes in with a cold, but on history, we also get this history of a productive cough that he's had for 2 years.
Mm-hmm. So I think the patient has chronic bronchitis.
Exactly. That's what I agree with. I agree.
Yeah. You said, you just remembered what chronic bronchitis is?
Yeah, we're going to review chronic bronchitis. And the symptoms of chronic bronchitis are 4 you need to remember: productive cough,
Mm-hmm.
cyanosis,
Mm-hmm.
crackles when listening to his lungs,
Mm-hmm.
and wheezing.
Mm-hmm.
4. And then you can make a diagnosis if there's a productive cough for at least 3 months in at least 2 consecutive years.
So we just remember that the cyanosis is due to smoking because it takes your oxygen away. We just remember that there is a lot of mucus, so there is cough.
Mm-hmm.
And because there is a lot of mucus, there is wheezing.
Exactly.
And the crackles is because the lungs are in a very bad shape.
Right. And the bronchodilators would only create a slight improvement as opposed to an asthma, which would have a more marked improvement.
Mm-hmm.
And like you noted, these patients are often hypoxemic, meaning cyanotic, and hypercapnic, meaning they have high amounts of carbon dioxide in their blood from the smoking itself.
Mm-hmm.
So let's go back to the case study. What is the likely diagnosis? Well, we say chronic bronchitis,
Mm-hmm.
and it's because of the cough being there for at least 2 years, and the history of smoking is very typical in these cases. And they have a history of chronic pulmonary infections. Now, why does cigarette smoking predispose to chronic lung infections? And this is a key question because nowadays in the news people are saying vaping is just as bad.
Mm-hmm.
So this is a good question.
Mm-hmm.
Now we'll have to probably go in a different video and really get into depth on vaping and its side effects.
But we can say for now that
Yeah, for USMLE purposes, where it's unlikely to have a vaping question, so it'll probably just be smoking. But I think it's interesting to have that video in as one of the medical talks videos. So I think we will include it. So let's just talk about what does smoking actually do in the lungs.
okay, this is interesting because the toxins in the cigarettes paralyze the mucociliary tract, and it results in impaired mucus clearance from the airway. So actually there is a paralysis
Mm-hmm.
in the tract.
That's
right?
right. Yeah. There's little hair cells that help bring the mucus up, and when you smoke, they get paralyzed, and now you can't bring the mucus up, and your mucus will now collect in the lungs.
So the cilia are the ones that are
And that's why some
paralyzed.
people who've been smoking for years, smoking for a lot of years, they stop smoking, all of a sudden say, I got sicker. Well, it's no, they didn't get sicker. What happened is now the cilia, the hair cells aren't any no longer paralyzed, and they're starting to work, and you're getting rid of all that junk that's been collecting for years and years and years.
Mm-hmm. That's very interesting.
But in this patient here, we're assuming he's still smoking, and so all that junk is still in his lungs.
And then you mentioned that the cells, the good cells, are replaced with goblet cells, which are the cells that produce the mucus, right?
That's right.
So the pseudostratified ciliary cells
Mm-hmm.
are paralyzed, and there is a replacement with goblet cells.
Mm-hmm. As well, you'll see histopathologically that there's a hypertrophy of the submucosal glands and goblet cells, resulting in mucus hypersecretion in both the large and small airway.
And why people call it perineoplastic? I think that it must be because there is a true squamous metaplasia,
Mm-hmm.
right?
That's
That
right.
is creating an environment susceptible to infection.
Right. So in this next cut, we're going to show you actually histopathology. And you're going to see on the top slide is the normal, and on the bottom is someone with chronic bronchitis. So let's put that on right now. Here we see a biopsy of a bronchial wall from a normal patient is the top one, showing normal pseudostratified columnar epithelium with scattered goblet cells overlying smooth muscle in a submucosal gland. Now the one here, the bottom one, is one showing chronic bronchitis. And you can see the difference there. It shows hyperplastic epithelium with mucous cell metaplasia overlying a hypertrophied submucosal gland. You see that there's the gland there, and there's the hypertrophied gland there. Okay, so you just saw the normal slide and the abnormal slide. So you get a good idea of what's going on with this patient from a histopathology perspective. Now, mucus hypersecretion is reflected by an elevated Reed index. And what is a Reed index? It's defined as gland depth or total thickness of the gland depth divided by total thickness of the bronchial wall between the epithelium and the underlying cartilage. It objectively measures smooth muscle hypertrophy.
Mm-hmm. So remember, some people mention a fat forced expiratory volume in 1 second over forced vital capacity ratio.
Mm.
So how does it work with chronic bronchitis?
Okay, so when we breathe in and we breathe out. Okay, and so what we're measuring is how much air is coming out in 1 second, right? And the hypertrophy of the mucus secreting cells, glands, and the mucus hypersecretion lead to a reduction in the airway diameter.
Mm-hmm.
So that makes it more difficult to expire.
Oh, yeah. So you mean that the expiration is longer
And harder, exactly.
and harder? Okay. So the forced expiratory volume in 1 second should be prolonged. And what about the forced vital capacity? Does it change?
Well, there's definitely a decreased FEV1 with smaller changes in the FVC.
Mm-hmm.
So that results in a reduced FEV1 to FVC ratio.
Because the forced vital capacity is not very, doesn't vary, and the forced expiratory volume in 1 second is prolonged.
That's right.
So that ratio should be smaller. Okay.
These changes are the principal causes of expiratory airflow limitation with minimal effect on the elastic recoil of the alveoli. Now, what is an acute exacerbation of chronic obstructive pulmonary disease, COPD? And what classes of medication should be avoided or prescribed with great caution in these situations?
Mm-hmm. An acute exacerbation means that the patient acutely starts having a lot of shortness of breath that they didn't have before. And also, when they go to see us, we do see that there is hypoxemia and hypercapnia, right? And those exacerbations usually are due to respiratory infections. And not only that, they also start coughing more often. And the main thing is that they are short of breath.
That's right. And these infections are such as acute bronchitis, pneumonia, and the drugs, any drug that suppresses respiration should be avoided. So that includes opioids, benzodiazepines, and barbiturates. Now, the other thing that should be avoided are beta blockers, which inhibit catecholamine-mediated bronchodilation. That should also be avoided. Now, which acid-base abnormality is commonly found in COPD patients, and what is its origin?
We thought about the shortness of breath, and we thought about the low oxygen. So if there is low oxygen, there must be hypercapnia, right? Which can lead to respiratory acidosis.
Right.
So as a compensatory response, the kidneys excrete additional hydrogen ions and reabsorb more amounts of bicarbonate, right?
It's a metabolic compensation, thereby restoring the pH toward normal.
Yeah.
Now,
So the pH is normal. Okay, so there is no acid to base abnormality because the pH is normal, because there is a compensation, right?
Yeah. Now, as it gets worse, you do get the respiratory acidosis. Now, how might mechanical ventilation lead to respiratory alkalosis? Mechanical ventilation lead to respiratory alkalosis.
Because you're giving a lot of oxygen, right? If tidal volumes and respiratory rate are set too high, this may float the patient to the other end of the spectrum, causing him to blow off too much CO2.
Right, so you go to the other, you go from respiratory acidosis to alkalosis, and this can develop
to
very rapidly.
respiratory alkalosis,
And
right?
it can be minutes to hours, and the patient can definitely decompose. And the renal compensation will try to bring it back to normal, but renal compensation occurs much more slowly and can take several days to complete compensation. So you have a patient getting sicker.
Yeah.
Okay, so we're going to do a review now of what we learned as we finish our case. We did a case study on chronic bronchitis. This patient came in with a cold, and it turns out to be a viral cold, but the big problem with this patient is that he has COPD, chronic bronchitis, from all the years of smoking. So let's review. Symptoms of chronic bronchitis: productive cough, cyanosis, crackles, and wheezing. Diagnosis: productive cough for 3 months and at least 2 consecutive years. Pulmonary function test yield an FEV1 FVC ratio that's less than 75%, and there's only slight improvements following the administration of bronchodilators. Patients will be often hypoxemic and have higher than normal amounts of carbon dioxide in their blood, which is called hypercapnic. Now, Dr. Ingrid will review the pathology and treatment and potential complications of chronic bronchitis.
Okay, we just said that hypertrophy of submucosal glands and goblet cells result in mucus hypersecretion in both large and small airways, which reduces airway diameter and obstructs expiratory outflow, right? The rate index that you mentioned is the gland depth, okay, over total thickness of bronchial wall. Objectively, that index measures smooth muscle hypertrophy, right? Now the treatment, remember, we can use bronchodilators and corticosteroids. That's the main.
Yeah, bronchodilators, corticosteroids.
That's right.
Okay.
And we can use antibiotics in case of acute exacerbations of chronic bronchitis, which are often triggered by infection. Okay? So drugs that suppress respiration, such as the opioids, analgesics, benzodiazepines, and barbiturates, should be used very cautiously.
Very cautiously, okay?
And just remember, what are the potential complications for chronic bronchitis?
Well, because of all the problems in the lungs, you're going to get right ventricular hypertrophy and right-sided heart failure.
Because the body's trying.
Ultimately, okay?
Yeah, it's trying to compensate. And so what they do, we cannot get enough oxygen into our cells, so what happens is that the heart starts working harder and faster. So that's the main reason for that.
Okay. So that concludes our case study. Thank you for watching, and if you like these videos, please like and subscribe. Thank you very much.